Welcome to the Design for Impact podcast. I'm Cara Prosser, an Aussie in London, an experienced designer and strategist obsessed with fixing the world's most broken systems.
And I'm Philip Lockwood-Holmes, an Englishman in Edinburgh, not New York. I work with leaders and organizations helping to turn good intentions into real-world impact. We are your hosts as we meet some of the world's most ambitious thinkers, builders, and changemakers who are redesigning the systems that shape our lives.
From ethical AI and climate innovation to women's rights, healthcare, and humanitarian work, each episode dives into the real stories behind people doing the hard, meaningful work of change. But at its core, we're exploring how can you use design and creativity for impact. Hi, Nneka. How you doing? Welcome to the Design for Impact podcast. So excited to have you on as a guest. Got loads of great things we're going to chat about today, but I think we'll just start with, giving the listeners an introduction to who you are. So tell us about you, your background, and what you're doing now.
Okay, well, thank you very much, Cara. It's lovely to see you. So I am a consultant physician in sexual health and HIV in London and have been in this field for, over 25 years. For the last 7 years, until about 2 weeks ago, alongside my clinical practice, I've also worked for ViiV Healthcare, which is an HIV pharmaceutical company, as the head of patient engagement. And I think sort of my early career followed a pretty standard trajectory, I think you might say, aside from the fact that I went to medical school in Papua New Guinea, which I guess is not standard, but was otherwise absolutely fabulous. And in my later career, my focus, along with sort of standard sort of my clinical practice in HIV and sexual health, I've developed an interest in HIV prevention, particularly in HIV prevention for women, but also in women's health. And then more recently, working in patient engagement at ViiV, my eyes have really been opened to an area of interest that extends far beyond my interactions with patients as a doctor. And it's been really interesting just to explore that part of life and my career.
I was just about to dive in to say, and that's where I got the incredible opportunity to meet you and work with you during a program of work, which was all around how we capture, store, gather, use, and action patient insights, patient data, information about patients in a better way. It's a really big challenge across healthcare right now. And so it's incredible to kind of work with you on that, on how we do that in a more sort of meaningful way. And so I guess from working with you, Nneka, I know, and one of the many reasons why we've sort of invited you on the podcast is you're one of the most not only accomplished, but passionate people about healthcare and how we can make better healthcare experiences for people and for patients. So tell us more about that. Yeah, what are the things that you're passionate about? Why are you passionate about creating better healthcare experiences for people?
I think doing this patient engagement job, and also just in my sort of regular clinical work, it's really clear that there isn't equity of access of healthcare to with regard to all the people who need and utilize healthcare services, health services. And I'm really interested in understanding and supporting, I guess, the development of the design of services to suit the people who use them, the diversity of people who use them, including across sort of the age spectrum, the gender spectrum, because I think, as in many things in life, there is no one size fits all. But I think a particular challenge now as people get older is how services adapt to the changing needs of people across their whole lives, given some of the challenges, for example, that people experience with regard to mobility, with regard to digital fluency in a world that is becoming increasingly digital, but in which we know that there are people who are left out. I think it's one thing to support people to develop digital fluency so that they can engage with services as they become more digital. But I think it's also important to recognize that there are some people who will really struggle with that. And so how do we keep services relevant to people who aren't able to come along on that journey? How do we ensure that those people continue to have access to services? And how do we include the people who use services in the design of those services? And that's something I think is really important, and that I had some experience of early in my career when we set up a young people's service.
And again, I think one of the many reasons why we've connected, right, Nneka, is I really feel like you're an experience designer. All of these kind of things that we do in experience design and co-design around getting people involved, to co-create something, even if that sort of, traditional design terminology isn't there, that's essentially been a big part of your practice throughout your career, right? So can you tell us a little bit more about that and sort of that co-creation and what it means to you and the opportunities in that space?
So maybe I'll just start with the reference that I made to our young people service. So when I first became a consultant, I started work in a community sexual health clinic. So a sexual health clinic that was part of Chelsea and Westminster Hospital, which is where I trained and which is where I worked, but which was located in central London. And there were lots of schools, and still are lots of schools around that area. And at the time I started practicing as a consultant, sexual health in young people was really bad. The UK had the highest teenage pregnancy rate in Europe. And there was a lot that needed to be done to sort of improve things. And so, given the fact that we were surrounded by lots of schools, we set up a young people service. But one of the things we were really clear about the need to do was to involve young people in the design of those services. And so we sent a survey to young people in the various schools around, but also there happened to be a pupil exclusion unit there in the area as well. And so while we felt it was important to involve young people who were in mainstream education, it was important also to involve people who you might not necessarily think about or who might be excluded from some of the, services that sort of children in mainstream school had access to. And we surveyed nearly 800 young people. We had a 100% response rate to our service.
Wow.
And basically they told us what they thought a young people service should include, what mattered to them, what didn't matter to them. And so we designed the service based on what they said, and it was really, really successful. And I think it was the first example that I had of how important it is and how successful it can be to involve the users of your services in the design of those services.
And was there any particular surprises from that survey compared to what you might have imagined, kind of if you'd invented it without doing that kind of inquiry?
There are a few actually, because we thought, most young people, for example, would not want there to be adults in the waiting room. That they would just want to have young people. But actually, most young people didn't care whether they were adults. I mean, they didn't want to see their parents in the waiting room. that was made pretty clear to us from the beginning. But yeah, they didn't really mind. What was really important to them, and this was not a surprise, was the promise and the delivery of confidentiality. Girls wanted to see female clinicians, nurses, doctors, and so on, but actually so did boys, and that was a surprise.
Wow. Okay.
More girls did, but a significant proportion of boys did. Younger people didn't mind if the service was attached to a hospital or a GP practice. But older people did not want it to be attached to any form of health service. They wanted it to be standalone. And luckily, because we were in a community, we were able to deliver that part, the part about it not being next to a hospital. But on the ground floor of the clinic where we worked, there was a GP practice, and many of the young people actually went to that GP practice. So we were able sort of to cater to the requests of both groups of people. But it was a really extraordinary service, and it was good fun.
That was great in terms of kind of looking at that research. I guess the other thing you do a lot is kind of work in partnership with patients. So, I mean, I guess that was a kind of an interaction whereby there was a survey. Are there other examples of your career, I guess, with the work that you did with Cara, in terms of kind of how you've partnered with patients or people?
I mean, so a lot of the partnership work, actually, no. I mean, so I've worked in partnership with people in the community and so on outside of my job at ViiV, but my job at ViiV was about creating, sustaining, developing those partnerships. And one of the things, so as you know, and as you would expect with a pharmaceutical company, the main aim of a pharmaceutical company is to make medicines. But what's really important to me, and I think to all pharmaceutical companies, is that the medicines that companies make and that they expect people to take should be made to or developed to suit the diversity of the people who are going to be taking them. And one of the things that I think is well known in the development of medicines, for example, is that the participation of women in clinical trials is often much less than the participation of men. And so when you have a large proportion of the participants in a clinical trial being of one sex or gender than another, there is the question about whether that medicine actually will suit the needs of the group that is not represented as much. And so, for example, when you look at HIV clinical trials, until very recently, only about 20% of participants in HIV clinical trials were women. And this is despite the fact that globally, 54% of people living with HIV are women. So
Wow. Yeah.
clinical trials are not
Not
designed,
matching,
or
does it?
traditionally
No.
no, it doesn't match. And so one of the things that I've been involved in over my career is conversations with women about being involved in clinical trials. Just talking to people who have concerns about participating in clinical trials, often for good reason, fear of being experimented on, not really understanding what the study is about, and so on. But having, but then on the flip side, saying, well, I don't know if if I'm prepared to take this medicine because it wasn't studied in people like me. And
Yeah.
so you have someone who is reluctant to be in a study because, for example, I think when you talk to many people of color, for example, because historically, I think research has not done well by them in terms of I mean, there are lots of data to show that in many in the development, well, not necessarily in the development of medicines, but a lot of research has harmed people of color. So there's a very famous study that is always quoted, and I think people get tired of it being quoted. But a study in Mississippi that soon after penicillin was developed that was used. So penicillin has always been the mainstay of treatment for syphilis, for example. And for many years after penicillin was developed, I think until about the 1970s, people, and I think these were mainly Black men in a prison in Tuskegee in Mississippi, were denied penicillin, even though everybody knew that penicillin was a treatment for syphilis. And so and I think this was in order for them to understand the natural history of syphilis, they didn't treat them. And there have been many such situations in which research has done a disservice to certain groups of individuals, such that there is mistrust of medicine, mistrust of research. And so you have on the one side people not trusting research, but on the other side being mistrustful of medicines that they believe were not tested in people like them. So how do you overcome the challenge, one, of reassuring them that nowadays, hopefully, things are done in a much more ethical way, against, if you really want to be sure that this medicine works well in people like you, it's really important that you are willing to participate in that research, and helping people to understand that the reason that we have the medicines that we have now is because people were willing to participate in research studies. And it's an interesting conversation. It's an ongoing conversation, but it's a really important.
My follow-up question was going to be, you talked a little bit about how you were talking to women one-to-one about clinical trials and trying to get them to be involved. I guess the question is, in the design of clinical trials and the communication that's there, is there a way to try and break down some of this nervousness and try and redress the balance in terms of more women taking part in clinical trials?
Yes, I think there definitely is. And so I think that there are conversations to be had to broaden the one-to-one conversations to women in the community. And so, there are lots of women link up with each other for lots and lots of different reasons. And so if you have a group of women who represent, for example, the groups of women you think should know about clinical trials and be interested in participating in clinical trials, bringing them together in the community is often a good way to reach them. I think it's important that the people who are speaking to them are people who they trust. And so that is often that can often be women who've participated in clinical trials themselves from the community so that they can share their experiences. I think it's important that when experts are engaged to speak about clinical trials, that they bear some resemblance to the people who you want to involve in clinical trials, particularly in areas where there is mistrust of in medicine, and I don't think that this is anything to do with racism or anything. I think it's just to do with the fact that people relate to people like them in general. And I see this, for example, in my clinic. So I'm going off on a little bit of a tangent here, but Cara, as you know, I'm very interested in menopause.
Yes.
But there's a lot of, menopause is only something that has recently started to enter the sort of mainstream discourse. For a long time, it's been a subject that's been quite taboo. There's lots of sort of judgment about what women go through in terms of women who don't have problems with it kind of think that women who do have problems in menopause are somehow weak, or, and there isn't an acknowledgement that actually people's experiences are different and everybody deserves to, to have their concerns validated and treated seriously. But there is also a whole conversation about HRT, hormone replacement therapy, and whether there is harm or there is not. And it's only recently that some of the myths surrounding HRT have started to be dispelled. But one thing that you often see, and you may have noticed this yourself, that in the public discourse about HRT, it generally, and it's not a surprise, but generally the people who are talking about it are often very attractive middle-class women, white women. And so when you're having a conversation with women who are not middle-class white women about HRT and about menopause, if somebody has never seen anyone who looks like them having that conversation, their first thought is, well, HRT isn't really for me because I've never seen anybody like me talking about it. And so it's often been helpful in my clinic when I'm having these conversations with African women, for example, for me to be African. It's useful because then I'm talking about this, and hopefully they will believe if I say, look, I treat lots of women with it. This is their experiences. They're more likely, hopefully, to at least consider it than they might be if someone else was having that conversation. And I think it's the same for research, that if you can relate in some way to the person who's speaking to you, you're hopefully more likely to at least consider it or engage with the conversation than if it's coming from somebody who you don't relate to.
Yeah. And I guess also kind of having a sidebar conversation about, I guess, kind of credibility and trust. Like I had an interesting situation when I went to my GP last time. It was really interesting that he actually Googled something to show me things on the computer from a third-party source, because I think that for him, he thought that I would find more credibility if there was a third-party source that mirrored what he was telling me, because maybe I wouldn't trust in experts anymore. And I think, this is a societal thing, right? About like, where does credibility and trust come from?
Absolutely. And I do that. I do it. Because, if you're saying something to someone, you're kind of saying it in isolation. But if you can verify it or allow it to be verified by finding another source who says it, a source that the person trusts, obviously,
Yeah.
then I think then that gives credibility to what you're saying. So, because I guess nowadays, why should I trust this person just because they say that they're an expert to your to what you just said? I mean, experts now are sort of dirty word these days.
Yeah,
I know, I know.
which is where the whole topic, about building credibility in medicine and
Mm,
how do you kind of get people who might be disenfranchised to take part in trials is even more of a challenge
yeah,
than maybe it was before.
yeah, it is, I think.
And Nneka, we've spoken a little bit around this kind of stigma that women have of all backgrounds in healthcare. The last conversation you and I had, we spoke a lot around judgment, and that actually women are we're kind of the worst ones in terms of how we judge other women and things like that. But I just want to loop back to the campaign that you did, the Risk to Reason, because I
Mm,
thought that was such a beautiful example of creativity in healthcare, but also, you literally just said around how, well, if I'm a woman and I see someone who looks like me doing something or using something, how that breaks down stigma, but also hopefully accelerates access. So tell us about that campaign, how
mm,
you went about
mm.
doing it, and just around that space in general.
Well, the first thing I have to say is that I cannot take credit for it, even though it was a wonderful, wonderful initiative. So I'll just give a little bit of background so people know what it's about. So Risk to Reasons was an initiative developed in the United States by ViiV Healthcare in the United States to address the fact that HIV prevention was not really working for Black women in the United States. So when you look at rates of new HIV infections in the United States, Black women are disproportionately affected. And there are lots of complex reasons for this. But none of the messages that were developed to address this large number of new HIV infections in women were working. And so ViiV Healthcare in the United States basically got together a group of women from communities, from Black communities um, across the United States to come together to discuss what the problem was, to acknowledge that there was a problem first of all, and then and this is, I think, where partnership comes in, and then together to think about ways to address the problem in ways that would resonate with women. And the reason I say in ways that would resonate with women is because I think this is the crux of why this initiative worked. So we know when you look at rates of new HIV infections, sort of in Western countries, in high income settings, there has been a tremendous reduction in new infections in men who have sex with men. And that's because there have been a lot of campaigns, a lot of initiatives to engage men who have sex with men in conversations about HIV prevention, and then to give them access to interventions that can reduce HIV transmission, such as PrEP, for example, pre-exposure
Yeah.
prophylaxis. Those campaigns have also, in many cases, been directed towards women. But the thing is that the messages are completely not in line with the way that women think, with the way that women behave. And so they have not resonated at all with women. I mean, one of the things that uh, so there are criteria that help you to know whether a gay man is more likely to acquire HIV in the next X period of time because of various things that might have happened to them. But those criteria don't apply to women. And so often a woman will come to clinic and someone will say, "Oh, do you know that you're at risk of HIV?" for example. And women, first of all, don't engage with the word risk at all. I mean, the word risk has connotations that you're doing something wrong. There's a lot of data to show that actually women don't even perceive themselves to be at risk of HIV, for want of a better word, even
So
in communities
interesting.
where the prevalence of HIV is high. So where many people around them have HIV, they don't. So using that kind of language does not resonate at all. And so this Risk to Reasons basically sought to change the language around HIV prevention for women, moving away from using terms like risk to thinking about it in terms of a woman's reasons for HIV prevention, and kind of doing it from the point of view of thinking about the woman as a whole and her sexual health as a whole. So not just focusing on HIV, but you have a woman who is sexually active and you establish that she's sexually active and you ask her, so, what's important to you with regard to your sex life and your sexual activity? Are you happy with your sexual activity? What are you intending to become pregnant? And if you are not, what things are you doing to try to prevent pregnancy? Have you thought about your risk of STIs, sexually transmitted infections? If not, what are your thoughts about how you might prevent that? And then incorporate HIV into that, so that it's a conversation about her as a whole and not a conversation just about her HIV risk. And after this was introduced into the United States, there was a lot more engagement of women in these conversations. Many more women started accessing HIV prevention services themselves. There were conversations about it in the community. And so last year now, we introduced this into the UK. And we're in the process of sort of rolling it out now, but we've had such good feedback about it. We did the campaign in the United States focused on Black women in general, because that's where the biggest issue has been. But in the UK campaign, we were really clear that we wanted this to resonate across, for women, regardless of their background. One, because HIV does not, it doesn't distinguish between a white woman or a Black woman. We know that there are many women who are not Black women in the UK who have HIV. And it's really important that campaigns and prevention initiatives speak to the diversity of women. And so we did this. So we've involved lots of women from different backgrounds in the sort of in the creation of this initiative. We've got women of South Asian origin. We've got white women. We've got Black women, and it's just a really beautiful campaign. And the imagery is gorgeous, and it really resonates. So we're hoping that this will make a difference.
I think for any of the listeners, check it out. Risk to Reason by ViiV Healthcare, ViiV, ViiV, and you'll find it. It is just a beautifully shot campaign. And I think it touches on so much of your work, right, Nneka, in terms of storytelling, patient engagement, patient experience, awareness, stigma. So I think it's such a beautiful campaign to kind of, I guess, round out your incredible tenure at ViiV Healthcare. But tell us a little bit more about some of the work you're doing in menopause and how, I feel like we're just so far behind on that journey. Like we've just started really talking about it, right? So what do we do? How do we kind of accelerate change in this space?
I think there's a lot that's starting to happen now. There are lots of advocates in the community and this is in communities around the world. I think there are some countries that are further ahead than others. The UK is quite far ahead. Australia is quite far ahead. In Europe, it's patchy, and in the United States, it's coming along, but it's still, I think there's still work to be done. And in many African countries, it's starting to really gain traction. I think one of the challenges has been about the fact that there is a perception often that this is just something women have to go through and you just have to suck it up because that's a woman's lot. And, maybe years ago when women, for example, didn't have careers that extended, into their 50s or 60s, perhaps it wasn't as noticeable as it has become as we see women working for longer and working through the menopause transition and having the impact of menopause, having affecting their careers and their ability to do their job. So it's become much more mainstream in a way, talked about more. There's a lot of work that is being done in organizations to support women going through the menopause transition. Cynically, I think this is often because of the fact that there's an economic consequence to this. So if a woman is, women who are going through the menopause transition who work basically are often at the height of their careers, doing their best work, so to speak. And so to lose them from an organization has huge financial consequences potentially, but also, loss of institutional memory. There are all sorts of downsides
Mm-hmm.
to letting women leave the workforce at that stage of their life, particularly if they don't want to. But there is also, it's also the case that some organizations have suffered where they haven't supported women through the menopause transition because they've been taken to industrial tribunals, for example, for constructive dismissal. Because even if they weren't dismissed because of their menopause symptoms, they have felt, for example, that they had to leave because they didn't feel that they could continue to do their jobs properly because they weren't given the support to. So there is increasing recognition, particularly in big corporate organizations, that women
Mm-hmm.
should be supported through the menopause transition. And I think it's to the benefit of the women themselves, but also to the benefit of the organizations to be able to keep women on. This is a temporary situation. Women don't struggle with this indefinitely. Eventually symptoms settle down. There are things that can be done to relieve symptoms. And so to be able to keep women on, if they want to stay on, is of benefit, to the organizations, to society as a whole. But I think what's really important is that women are having conversations about it. Um, Governments are supporting it, so the UK now has this women's health strategy that includes menopause. Um, uh, there's a lot more recognition of the impact that menopause can have, but also of how to mitigate the negative impacts of menopause and the benefits of that to society.
And I think it's just, women's health in general. I looked at a stat the other day, which was, I think that, you know, it's 1% of all healthcare investment, and that's across a lot of
Mm,
different industries
yeah.
within healthcare, but only 1% is sort of looking at female health. So we've started, but we've still got a long way to go,
A,
haven't we, Nneka? And I
a,
even think
a
about
long way.
how we talk about women's health and sexual health since I was a teenager, and things have changed a lot there as well, right? And we're just getting to know more and more about our bodies and more
Mm.
about how women can be supported. And I think it's a really interesting conversation around that kind of commercial impact. And this is what design for my business is all about, right? In terms of human-centered design, but also commercial growth. Like, we have to keep that hat on at all times. And ultimately, getting women back into the workforce or keeping them in the workforce during menopause or through pregnancy, right, ultimately is about equality, right? And what does equality bring our economy, and what does equality bring our world, right? And we haven't quite figured that out. I mean, you look at some of the more like the Nordic countries that
Mm.
maybe have some of the childcare and mat leave benefits a little bit more sorted out, but it is still such a long road to sort of go down. But I wanted to ask you quickly about, you're about to hopefully head off to Botswana and some places in Africa, and I'd love you to tell us about what you're doing there.
So it's not kind of completely decided yet, but I am interested in doing some work, women's health work, particularly in some African countries that I've visited before. And Botswana potentially is one of them. Um, and this is sort of work related to HIV treatment and prevention, but also women's health work, and particularly focusing on not necessarily on menopause. So I'm always conflicted about saying menopause as opposed to issues related to aging, because menopause I think is seen as this niche thing, and it's often not seen in the broader context of helping, of being part of the way that women age and having a significant impact on how women age. And I'm really interested in how women age. Um, and in countries where the life expectancy is now increasing, aging is having a bigger impact than it has in the past.
Hmm.
So for example, where the life, particularly in countries that were really badly affected by the HIV epidemic in the beginning, where the life expectancy was significantly shortened. Now, with really effective treatment, people are living much longer, and the life expectancy of people living with HIV who are on treatment now approximates the life expectancy of people in the general population.
It's
And so that
insane.
brings, so that brings with it some of the challenges, but also the opportunities that you can see in aging populations. But because the sort of consequences of aging that we see in high income settings, cardiovascular disease and so on, weren't in the past as common in sort of developing countries as they are now, there is the need to understand what the impact of those conditions of aging will be in those countries. Is it different? Are there things that need to be considered that haven't been considered because the environment is different? And I'm really interested in that, and that's the sort of work that I'm interested in sort of pursuing.
And I guess for me, as a kind of a branding and kind of communications thinker, like somehow also kind of talking about kind of how women age well, it's a more, I guess it just phrases it in a more proactive perspective rather than
Yeah,
menopause being a challenge that some people face in different ways, right? It completely looks at, and I guess if we look at,
absolutely.
the global sense of the fact that more people are living longer, then the art is how do you make sure that more of those years are healthy, well-being years. And that, I think that's a really kind of, as a reframe, I like that from it.
Yeah. Yeah. And I think that's really important, Philip, because, so we know that women live longer than men. I mean, just
Yep.
generally, but actually women have fewer healthy years than men. And we don't fully understand why that is. I mean, we do to a certain extent, but I think it speaks a bit to what you've just said. How do we ensure that the years that women live that are longer than the life expectancy of a man are lived healthily? And it's really important that there is not very much point living a long life if it's not a healthy life,
Yeah,
or at
absolutely.
least if a large proportion of it is lived with ill health.
Yeah, so I'm going to guess kind of pulling at 3 threads we've got here. Well, actually, I'm going to do 4 threads. One is health for women sucks.
Yeah.
It
Secondly,
does, Philip.
yeah. Secondly, pharma isn't investing enough in women only, if it's only 1%. I guess the third thing is, this focus on it being well lived, both from a economic perspective, people
Mm,
having a effective, fulfilling role in society, whether that's employment or not, but
mm,
also from a, the public purse perspective. Healthcare costs so much in the later years. If you can have
mm,
more healthy years, then, that leads to a better society, doesn't it, all around?
yeah.
So, yeah, so
Yeah.
much work to do. And you're going to do it all. It's brilliant.
I am. Yeah, that's me. Yeah.
Well,
It's
that perfectly.
exciting.
It is exciting, and the world is so lucky to have people like you, Nneka, because I feel like, the communities need the support. But I think that leads to my last question really nicely, which is, we've spoken about lots of things today, and really we could have done another 5 episodes on those 4 threads you just mentioned, right, Philip? But if there's 1 or 2 things you'd really love the listeners to take away from today, what would it be?
I think all of us at some point are likely to encounter health services. And I think I think we should all proactively try to find ways that we can be involved in the development of those services or the creation of those services so that we can be sure that they work for us. And even if you're not necessarily doing it for yourself, if you look at the people around you and you understand how they navigate health services and how difficult it can sometimes be, um, seek out their views and share them. So I think one of the things we talked about a little while ago was about how we ensure that older people um, have services that work for them. And,
Yeah.
rather than having an older person have to go to lots and lots of different appointments over the course of a week or a month, is there a way that the people who are providing their care can somehow all come together at the same time and have that person either physically there or virtually there, so that everybody can have a conversation about what this person needs, so that that person can say what they need to everybody who's involved in their care. And that way create something that works for that person. And I don't. It shouldn't be beyond the wit of all these really bright people who create health services to do this.
Yeah, and I think the other thing actually you mentioned last time, and this is something I've reflected on afterwards, is the empathy from people using health services. That actually, on the vast majority of time, the person you're seeing is doing their best within a system, and actually
Mm,
maybe that system is holding them back. So be
yeah,
empathetic, be open, and think well of the people you're working with, because they probably are
yeah,
doing absolutely everything they can.
yeah. No, that's absolutely right. I think, yeah, systems often work against the people either delivering the care and receiving the care. And I think, yeah, I think on both sides, it's really important to be empathetic. For patients to understand that clinicians have challenges to deliver the services that they want to, but clinicians also understanding that it's really important to understand what it took for this person in front of you to navigate the healthcare system, and so end up in front of you. And it's often not straightforward. But that's where it's so important that those conversations happen, that
Yeah.
people who deliver services and people who receive services can talk about their experiences. So together they can help to design services that work for everyone.
What an amazing ending you delivered
I
there.
know, I
Yeah,
know, I know.
fantastic.
I know. Thank you so much, Nneka. Honestly, I could have you for the rest of the afternoon. But I think you touched on
Oh,
so many things there around, a lot of our listeners are designers and creatives, and you touched on so many things around empathy and listening and kind of co-creation. Like I always say, there's an inner experience designer in you, and it's been so fantastic to work with you and also to have you on the podcast. So thank you so much, Nneka.
thank you, Cara, and thank you, Philip. It's been great fun, actually. Thank you.